In this chapter, we will discuss the clinical presentation and management of carotid cavernous fistulas. Carotid cavernous fistula, or CC fistula, consists of arteriovenous connections between the ICA or ECA and veins of the cavernous sinus. The most meaningful classification system for CC fistula subdivides these entities into either direct or indirect lesions. Direct CC fistula consists of a direct connection between the ICA or one of its cavernous branches and veins of the cavernous sinus. This can essentially be conceptualized as a hole in the cavernous ICA, with subsequent arterial flow into the cavernous sinus. The etiology of these lesions is usually traumatic. However, they can also occur after rupture of a cavernous ICA aneurysm or spontaneous rupture of the ICA, which can occur in the setting of connective tissue diseases. Indirect CC fistulas also consist of fistulous connections between branches of the ECA and/or ICA and veins of the cavernous sinus. However, for these lesions, the connection is within the dural leaflets surrounding the cavernous sinus, and thus indirect CC fistulas are more appropriately conceptualized as true dural arteriovenous fistula. In order to understand CC fistula, it is important to have a good understanding of cavernous sinus anatomy. The cavernous sinus consists of a plexus of veins contained within an extradural space lateral to the sella. As such, it may be more appropriately referred to as the lateral sellar compartment. This space is also in continuity with the epidural space of the spinal canal. It is important to emphasize that the cavernous sinus is not a single venous leg, but rather a plexus of multiple veins with discrete drainage patterns. This fact is important for the safe and effective endovascular treatment of CC fistula. In general, there are 4 separate venous compartments within the cavernous sinus, each with its own typical venous inflow and outflow patterns. The antero-inferior space receives inflow from the superior and inferior ophthalmic veins. The lateral compartment receives inflow from the sphenoparietal sinus and superficial middle cerebral vein. The posterior compartment is in connection predominantly with the inferior petrosal sinus, but also the superior petrosal sinus and basilar plexus. Finally, the inferolateral compartment is in continuity with the pterygoid venous plexus via the vein of foramen ovale. It should be noted that venous blood flow through these compartments can be bidirectional and dependent on an individual patient's pressure gradients. These gradients are also obviously deranged in the setting of a CC fistula, hindering normal venous drainage patterns and leading to the manifestation of symptoms. The cavernous sinuses are also interconnected by the anterior and posterior intercavernous sinuses. Panel A of this figure shows the important venous anatomy surrounding the cavernous sinus. The bottom panel depicts a direct CC fistula with a connection between the cavernous ICA and a vein of the cavernous sinus, leading to sinus engorgement. In this example, venous outflow is through an enlarged superior ophthalmic vein, likely producing significant ocular symptoms. This figure simply shows the arterial branch anatomy of the cavernous ICA. The 2 main branches are the meningohypophyseal trunk, which typically originates at the dorsal posterior bend of the cavernous ICA, and the inferolateral trunk, which originates just proximal to the anterior genu and projects laterally. CC fistula can result from an arteriovenous connection between any of these branches and a cavernous sinus vein. We will start by reviewing the clinical presentation and management of direct CC fistula. Again, these consist of a direct connection between the cavernous ICA or one of its branches and a compartment of the cavernous sinus. These are typically high-flow lesions, and they usually require treatment. Direct CC fistulas are generally the result of facial trauma. However, they can also occur iatrogenically, for example, after transsphenoidal surgery, or can occur spontaneously in the setting of connective tissue diseases. The classic symptomatology of direct CC fistula consists of the triad of proptosis, chemosis, and visual loss, though all 3 of these symptoms are typically not present. In general, the presence of significant proptosis denotes involvement of the superior ophthalmic vein. Diplopia can be due to cranial nerve compression within the cavernous sinus or cranial nerve ischemia. The nerve most often affected is the abducens nerve, likely secondary to its close apposition to the cavernous ICA. Cortical venous drainage can also occur with CC fistula, and these patients are at risk of intracranial hemorrhage. Alternatively, significant cortical venous drainage and associated venous hypertension can result in focal neurologic symptoms or seizures. The frequency of symptoms associated with direct CC fistula noted in a large case series is noted on the bottom. While non-invasive imaging can raise suspicion of a direct CC fistula, particularly in the presence of characteristic history and examination, formal angiography is necessary to confirm the diagnosis and to characterize the site of the fistula and venous outflow patterns. Generally, bilateral internal and external carotid distribution should be imaged, as well as the posterior circulation. In certain instances, the exact location of the fistula's tract can be difficult to visualize, in which case adjunctive techniques consisting mainly of ipsilateral common carotid artery compression at the level of the neck during either anterior or posterior circulation injection can be performed to enhance visualization. As stated previously, direct CC fistulas are typically high-flow lesions that usually require treatment. Specific indications for treatment include increased intraocular pressure, visual decline, a disabling bruit, or obviously intracranial hemorrhage. In the modern era, endovascular embolization via transarterial approach is generally considered first-line therapy. The transarterial approach is chosen as the site of the fistula can usually be easily catheterized from within the cavernous ICA. Many direct CC fistula can be treated with simple coiling. However, the need for dense packing can increase the risk for post-procedural cranial nerve deficits. Alternatively, a loose scaffold of coils can be deposited followed by infusion of liquid embolic agent, obviating the need for dense coil packing. This strategy does carry the risk of reflux of embolic material into the ICA, as well as cranial nerve ischemia due to occlusion of small arterial feeders. Covered stents have also been used with good associated outcomes, and more recently, flow-diverting stents have been used to treat direct CC fistulas. These have generally been used as an adjunct to transvenous embolization, in which the flow diverter is placed first within the cavernous ICA, followed by either coil or liquid embolization from within the cavernous sinus. There have also been reports of flow diverters used as a standalone therapy. However, this strategy requires further investigation and validation. This figure demonstrates the treatment of a direct CC fistula caused by rupture of a cavernous ICA aneurysm. This patient had a known cavernous ICA aneurysm, as seen on MRI in panel A, that had been managed conservatively for a period of years. She subsequently presented with severe retroorbital pain and proptosis suggesting a CC fistula, which was subsequently confirmed on angiography. The rupture site on the aneurysm can be seen in the early arterial phase in panel B, and in panel C we can see flow to essentially all the venous tributaries of the cavernous sinus. Contralateral carotid injection demonstrated brisk filling of the right ICA territory, indicating that the right ICA had essentially been functionally occluded by the fistula. Given the patient's excellent collaterals, we elected to treat this lesion with coil sacrifice of the right ICA. In panel E, one can see coils deposited within the distal cervical and petrous ICA, as well as within the cavernous ICA aneurysm. Post-procedural angiography demonstrates brisk bilateral ICA territory filling with no residual filling of the aneurysm or associated fistula. We will now review the clinical presentation and management of indirect CC fistula. As stated previously, the fistula's connection for indirect CC fistula occurs within the dural leaflet surrounding the cavernous sinus, and thus these lesions can be conceptualized as true dural arteriovenous fistula. Indirect CC fistula are more common in women and are usually diagnosed in the 6th or 7th decades of life. It is important to note that spontaneous regression of these lesions is not uncommon. In general, the clinical presentation of indirect fistula depends on the pattern of venous drainage. Ocular symptoms predominate when drainage is anteriorly through the superior ophthalmic vein. Posterior or lateral drainage producing cortical venous hypertension can result in focal neurologic symptoms, seizures, or even hemorrhage. Similar to direct CC fistula, formal angiography is necessary to confirm the diagnosis of an indirect CC fistula and characterize venous drainage patterns. In a retrospective case series, the predominant route of venous drainage was through the superior ophthalmic vein in most cases, followed by the inferior petrosal sinus and contralateral cavernous sinus. Given the propensity for indirect CC fistula to spontaneously regress, an initial trial of conservative management is a reasonable option, particularly in the setting of mild symptoms or low flow demonstrated on angiography. Historically, patients were recommended to perform intermittent ipsilateral carotid compression to promote fistula thrombosis. While this technique was associated with fairly high rates of fistula regression, we suspect that this simply represents the rather benign natural history of the disease. In the presence of severe or disabling symptoms, treatment of indirect CC fistula is warranted. Endovascular embolization via transarterial or transvenous approach is considered first-line therapy, though our preference is a transvenous approach when feasible. Embolization can be performed via simple coiling or coiling combined with liquid embolization. This figure contains angiographic images from a patient who presented with left-sided retroorbital pain and chemosis. A lateral view of a left ICA injection demonstrates shunting into the cavernous sinus from branches of the cavernous ICA. In the later arterial and early venous phase, very sluggish outflow through the superior ophthalmic vein is seen. Given the slow flow, this patient was managed conservatively and was brought back for follow-up angiography several months later. On the repeat study, there was minimal residual shunting into the cavernous sinus, highlighted by the black arrow, and no filling of the superior ophthalmic vein, suggesting that the fistula was nearing complete thrombosis. When treating indirect CC fistula, we prefer a transvenous route given that arterial feeders are typically small and tortuous, making them difficult to catheterize. The ipsilateral inferior petrosal sinus is the most commonly utilized route to access the cavernous sinus and can even be used in the setting of sinus thrombosis. In these cases, gentle twirling of a microwire can typically cross the thrombus and reach the cavernous sinus. When access through the ipsilateral inferior petrosal sinus is not feasible, alternative routes include the contralateral inferior petrosal sinus via the inner cavernous sinus, the superior or inferior ophthalmic veins, or cortical veins in the setting of significant cortical venous drainage. Alternatively, direct percutaneous puncture of the cavernous sinus via the foramen ovale under fluoroscopic guidance has been reported. Finally, direct puncture of the superior ophthalmic vein within the orbit is an additional route. However, this carries the risk of blindness from an intraorbital hematoma given the inability to compress the orbit to obtain hemostasis. This figure depicts the endovascular treatment of an indirect CC fistula using a combination of coil and liquid embolization from a transvenous approach. The patient is an elderly female who presented with retroorbital pain and proptosis. A lateral view of a right external carotid artery injection demonstrated arteriovenous shunting into the cavernous sinus, highlighted by the circle. Selective ascending pharyngeal angiography shown in panel B demonstrated arterial supply to the fistula from branches of both pharyngeal and neuromeningeal trunks. Panel C shows an oblique view of a right ECA injection and demonstrates venous outflow through the contralateral inferior petrosal sinus via the intercavernous sinus, in addition to the ipsilateral inferior petrosal sinus. To treat the fistula, a microcatheter was navigated to the cavernous sinus via the ipsilateral inferior petrosal sinus. Selective venography is shown in panel D. Coils were subsequently deposited first, followed by liquid embolic agent. Control right common carotid artery injection after embolization demonstrated complete obliteration of the fistula. Outcomes after the endovascular treatment of indirect CC fistula are generally quite good, with most fistula obliterated after a single treatment. Clinical outcomes are also favorable, with high rates of symptom resolution. In general, symptoms related to intraocular pressure typically resolve first. However, some patients experience a paradoxical worsening of symptoms after treatment, followed by improvement. This clinical course is thought to be related to thrombosis of the fistula and transient worsening of venous hypertension, followed by improvement after rearrangement of venous drainage patterns. Cranial neuropathies secondary to CC fistulas are also likely to improve, however, have been shown to persist in roughly 10% of patients. An alternative treatment modality for indirect CC fistula, specifically low-flow CC fistula, is gamma knife radiosurgery. Particle embolization of these fistula to reduce flow has been shown to increase the efficacy of subsequent radiosurgery. This schematic depicts the management of both direct and indirect CC fistula. In general, if a CC fistula is suspected, angiography is warranted. Most direct CC fistula require treatment, and we prefer a transarterial approach. Simple coiling is usually an effective treatment strategy, though coiling in combination with liquid embolization can also be performed. Second and third line options include covered stents and potentially flow diversion therapy. In the setting of mild symptoms, indirect CC fistula can be observed given the high rates of spontaneous resolution. In the setting of persistent or worsening symptoms, treatment is warranted. Our preference is for transvenous endovascular embolization with coils and/or liquid embolic agents. For low-flow fistulas, gamma knife radiosurgery with or without preoperative particle embolization is an alternative option. Thank you.